This next question is from a listener named Matthew, and he asks, I'm a PT student and have learned all these special tests, but not really sure how to use them clinically. Any advice?
Matthew, great question. If I could change the name of these tests, I would change it to something else other than special tests
Not so special
because
tests.
they're really not so special. I think they used to be special,
Mm.
but as research has evolved, we're learning that they're really not as special as we once thought that they were.
Mm-hmm.
So the reason that they're called special tests is the thought is that if we do this clinical test, it then will give us this diagnosis that tells us that this is what's happening. And then if we can say that this is what's happening, then we can form the solution, the treatment around this thing that is happening. I can give perspective from being a student and learning all of these special tests and going through and getting my board specialization in sports and learning all the clinical test batteries. I can give perspective from being a professor that had to teach all these special tests. I can give perspective as now being a mentor to mentees of practicing PTs of how do we use these special tests. It's a very dynamic discussion, and I'm trying to figure out how to limit it down.
Channel it.
So I'm going to do my best here to talk to the PT students, the PTs, the healthcare providers, but then also to the general population, in which Brandy can help me out
Okay.
with that. So special tests, all of these were made, and they tend to come from more of an orthopedic population. Again, that if we do this test, it says that this is a thing that's happening. For a test to be special, it has to be compared to a gold standard. And then from that gold standard, we start to get test properties of validity. The higher validity that you have means that this test is a valid test to show that this is the actual diagnosis that is happening. Let me run through an example here. Let's say we're trying to diagnose someone with a rotator cuff related shoulder pain or shoulder pain. And we're trying to say it's the supraspinatus tendon. Like we're trying to get specific. Supraspinatus tendon. The gold standard to this would be doing imaging. And the image shows that the tendon is abnormal. So that is the gold standard. I don't agree with that gold standard, but that's the gold standard to date. So then this test is developed to say, if we do this test and it's positive, how much does it match up to what the gold standard was, which is the image in this case? And then how much likelihood do we put into this that it's the true cause of what's happening and not other factors? So now we're getting into likelihood ratios, which there's a lot of statistics in it that can get confusing. So the test for supraspinatus tendon is that you lift your arm up, you turn your thumb down, you can hold it there, someone gives you pressure, or you can just lift it through that range. And if that's positive, then all right, you must have a supraspinatus tendon pathology, which is part of the rotator cuff. So let me back up and show why that's not a good special test. Our gold standards are now more like bronze standards, or I don't know the other models. There's no medal for fourth, fifth, sixth,
less
but
than.
very much less than a gold standard. The reason being is because when imaging was done on asymptomatic populations, and this was in 91% of the population, abnormalities were shown on the rotator cuff, and they had no pain and no symptoms whatsoever.
Mm-hmm.
So now that our comparison to the gold standard has changed. So now with this test of lifting your arm up, how can we say that that's due to your supraspinatus tendon being pathological? Because even when you do that test, there's nearly 9 other muscles that are equally active. So now this test that's saying that this is happening isn't valid. The likelihood ratio goes down. So I asked, what's the point of doing it? Like, why do we use these things?
Mm-hmm.
In students, for the shoulder alone, there's over 70 special tests that are taught and that they're responsible for knowing and regurgitating on an exam and showing that they can actually do this test out in practice. So there's a lot of growth that needs to happen in that system. So now let me back up, because that's the case of why special tests don't really need to be used, because they're not giving us the data that we thought that it would be giving. When a special test is appropriate is when it does have good test properties, and it's for something that we're trying to decide, should they be referred? Right? So if someone, fractures their leg. It's probably good to use a special test to say, yeah, this is fractured, you should go to the hospital. Someone comes in, they're a younger athlete, they have a full rotator cuff tear, you lift their arm up and it drops down to the side. Good time to have a special test to say, yeah, it's high likelihood that you have a full rotator cuff tear, and that because you are young and active, we may want to proceed with other interventions. So let me do this test, that's positive. Okay, we should refer you to other care, but we can continue to start with our care to bring down your symptoms.
Mm-hmm.
So there is a time and place for these special tests, but they tend to be in these direct access situations when we're trying to figure out where the person should be directed. Are they appropriate to be in physical therapy? Do they need to go see an orthopedist? And you have to be able to determine that. So now, from my sports specialization, we learned that we should put these clinical tests together into a battery of tests.
Mm.
And that if we use a battery of tests together, then we can be a little bit more certain that this is actually the thing that's creating the symptoms. And to quote a mentor in the field, if you have one pile of dog poo and you put it together with another pile of dog poo, what do you have? A bigger pile of dog poo.
Yep.
So I think we started to be a little bit on the right track of, well, if we combine these tests together, they're more powerful. But the bigger issue is that the gold standard is not the gold standard. So now we're still comparing it to this thing that doesn't really, it's not explaining why they have symptoms. It's not explaining why they have pain. So we can't put all of our time and effort and credibility and diagnoses into these special tests.
Mm-hmm.
Oftentimes, and what we're seeing is that diagnoses are becoming more broad, which they should be because pain is very complex, that we can't say that your shoulder pain is due to a supraspinatus tendon.
Mm-hmm.
It may play a part, but so does your sleep. So does your fulfillment. So does your gratitude practice. So does your nutrition. So does all these other things that make you a human. That plays a role in this shoulder pain. So what I will tend to tell people is we'll go through, we do objective tests that have numbers on it and show them that, hey, we tested your conditioning of your shoulder and you hit 15 newtons of force with your external rotation. Internal rotation, you hit 20 newtons of force. That's good. That's a good ratio. On this side, you had 10 newtons and then 20 newtons. That's 50%. We want to increase that to 66 to 75%. Like that's a good ratio for your ER to IR to be at. Well, now we have something to work towards. Is it explaining why they have their symptoms? No. Is it a piece of the puzzle? Absolutely. But there's all these other pieces that we mentioned earlier that play a role into that. So wrapping that long segment up, the biggest advice I have for you, Matthew, is that the greatest thing that you can do as a clinician and as a provider is to listen to your patient. This is the biggest change I've made in my practice. I came out of school, I had all these special tests, like 70 for the shoulder. I can tell you that's your supraspinatus versus your teres minor. I can tell you that it's this. I can tell you, no, you can't. The tests do not allow you to do that. But that I was like, this is what we should do, because then I get more info, and if I have more info, then I can treat better. Well, what I learned is that the more that you listen to your patient in the subjective part of your examination, and you use true active listening, and you're there with them and they open up and share their story with you, by the end of that conversation, you're going to have a really good idea of where you need to go. Mm-hmm. You might use screening, you might use a couple objective tests, you might use some tests to rule a couple things out, but it really limits it down. And I will say, don't use a special test just because you think you need to use a special test because you learned it in school. If you're using a special test, you should know why you're using it. And to that point, any movement that you're giving out, any modality that you're using, any rep scheme that you're using, there should be intention behind it. Mm-hmm. Why am I using this? Why am I doing this? And then I'll say too, we do offer mentoring to clinicians, and it's something that I really enjoy because they have a good fundamental base, but they're eager to learn more and to get a little bit more up to date. And how do I spent 7 to 8 years in school learning these tests, and you're telling me that I just shouldn't use them all. Well, then what should I be using? And there's a whole framework, there's a whole system that we use to really help. Is this external load? Is it internal load? Is it a combination of both? And what puzzle pieces, what levers do we need to pull? What outside help do we need to get this person to where they want to go to? Anything you would add
That's
into
awesome.
that long
No, that's
discussion?
awesome.
I hope it painted the picture and didn't confuse people or
No,
lose people in it.
no, I thought it was perfect. I think too, for our listeners who may not be PT students or, in the field in general, the last point that you made was very simple, but there could be a combination of external and internal load that people are going through. And I know for me, I had an injury, in high school, that external load, right? But there was a lot of internal load going on, but I was immature, didn't really understand what internal load was and all the things. And so my doctors probably did a bunch, I don't even remember, but they would have done a bunch of special tests. I never felt listened to by any of the doctors, but I look back and I'm like, man, if one of those doctors would have just realized the fear that I had, because I think the biggest thing was I was afraid that I wouldn't be able to play sports again. I was afraid that I'd be out and lose an opportunity for a scholarship, all these things, which ended up being the case. I ended up being injured for a very, very long time, wasn't able to go to college for sports. And like the thing that I loved the most in the world at the time was sports, and I lost it all. But none of the doctors like acknowledged that internal load. And so for someone who's listening who may not be in the field, but may know people who have pain or go through injuries, realizing that sometimes it's only internal load, but usually if there is external load, there's internal load as well. Like there's always going to be internal load, right?
Yeah.
And then there's often external load, but I really believe you can't have external load without some sort of internal load happening.
Yeah, and I kind of chuckle at some of the posts you see on social media. This exercise will fix your back pain. This one exercise is going to solve your back pain. It may help. It may be part of the puzzle.
But growing in peace and gratitude.
Growing in peace and gratitude. And asking the question, well, what really brought on that back pain? And is doing a cat camel going to be the thing that really solves your back pain long term? Probably not. It might be a good symptom modulator,
right,
to then allow you to get out of that space of very high level pain, where then you can reflect a little bit more and retrospectively look back and go, wow, my habits and my patterns and my behaviors, and I was in a toxic work environment, a relationship, whatever it may be. I've never worked with an athlete that had an injury, that had the injury at the time in their life that they were at their peak and doing great and didn't have high internal load.
Right.
And the data is starting to show this. The clinical practice guidelines are starting to ask more questions of this psychosocial model and how it's related to tendon pain. We see it all the time in our youth athletes. And I'm really starting to wonder, like, it was called the biopsychosocial model. And I'm wondering how long the bio stays. And it used to be like capital and first. And I'm almost like, I wonder if it should be psychosocial bio.
Yeah.
Because we know that the emotional component and those factors play a much bigger role in the pain response than biomechanics do. And there's a ton of data on biomechanics. We used to think that dynamic knee valgus was the cause of ACL injuries and ACL tears. Now we're learning that position happens after the ACL has already torn. And it's already torn because the feed-forward mechanism has failed. How's the feed-forward mechanism failed? Well, because something in their brain is fearful and not getting the message to the movement system.
Right.
So now we almost have to go back and go, oh, maybe we don't need to do 30 clamshells as part of a prevention program. Maybe we just need to ask our athletes, how are you doing? You doing all right? Like, really, are you okay?
Right.
Like, I work with an athlete now that has so much on his schedule.
Yeah.
That sometimes our sessions are taking 5 minutes to just chat and just talk.
Need to like debrief.
Yeah. How's your fantasy football team going? Who are you getting in free agency? What trades you making?
Yeah.
Like, whoa. Oh yeah, I get to talk. I get to sit down a little bit and like have some time. And it's so important for all youth athletes, for lifelong athletes, which is everybody that's listening to this podcast and
Yes.
everyone in the future that will be listening to this podcast. If you're thinking that I am not an athlete, I'm not a lifelong athlete, you are, you just don't know it yet.
Yeah.